Welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is about medical assistance in dying and the implications for nursing. This session is being recorded for nurses who are unable to participate today. My name is Josette Rousset and I'm an executive advisor at the Canadian Nurses Association, and I will be hosting this webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you will see on the right side of your slide. We will address as many questions as time allows. The certificate of participation will be emailed to you alongside the link of the recording of this webinar. And now a little bit about our presenter today, Barbara Pursuit. Barbara holds a Canada Research Chair in Health Ethics and Diversity in the School of Nursing at the University of British Columbia's Okanagan campus. Her program of research seeks to improve palliative care by focusing on developing rural models of support, enhancing nurses' competence, and providing care across diverse populations. Let's now turn it over to Dr. Pursuit to start her presentation.
Thank you, Josette. So our objectives for the day are to first understand how contextual factors influence how MAiD is being enacted and experienced by nurses, to gain knowledge of what nurses consider to be good nursing care in the context of MAiD, and to analyze the moral tensions that characterize nurses' involvement or non-involvement in MAiD. But let's begin with an introduction to MAiD. I think it's difficult to understand some of the research without first understanding some of the national context. Medical assistance in dying, or MAiD as we know it, was legalized in June 2016 through Bill C-14. This legislation was, of course, created in response to the Carter decision in 2015, in which the Supreme Court of Canada struck down the Criminal Code's prohibition on physician-assisted suicide. In the legislation, MAiD is defined as A, the administration by a medical practitioner or nurse practitioner of a substance to a person at their request that causes their death, or B, the prescribing or providing by a medical practitioner or nurse practitioner of a substance to a person at their request so that they may self-administer the substance and in doing so cause their own death. It's interesting to note that Canada has taken a somewhat different approach to assisted death than other countries. Rather than simply decriminalizing it, Canada chose to legislate it. Lausanne has suggested that along a continuum of approaches that countries can take to assisted death, the legislated approach is the hardest approach. So what he means is that legislation brings particular obligations that may not be present in the case of decriminalization alone. Lausanne has suggested that in the case of legislation, there is a specific binding law, a precise, specific, clear rule for every practice, and the designated third party to which the state delegates authority is the legislature. It's important to also note that this legislated approach is even more significant when you consider the federal and provincial responsibilities for health care. The Canada Health Act lays out particular responsibilities that the provinces and territories are then responsible to fulfill and oversee. So for a more fulsome discussion of this, we've published a paper in Nursing Philosophy that you may want to refer to. You'll be supplied with a reference list at the end of this seminar. But the main point is that we find ourselves on rather unique grounds here in Canada. The legislation spells out the eligibility criteria for MAiD. Persons must be eligible for health services funded by the federal government or a province or territory. They must be 18 years of age and mentally competent. Further, they must have a serious and irremediable medical condition as defined by serious illness, disease, or disability, an advanced state of decline that cannot be reversed. They must be experiencing unbearable physical or mental suffering that cannot be relieved under conditions acceptable to the patient, and be at a point where natural death has become reasonably foreseeable, but this does not imply that the condition is fatal or terminal. And it's important to note that the Quebec Superior Court recently struck down the reasonably foreseeable requirement. They ruled that the provincial and federal legislation was unconstitutional, and thus we can most likely expect some changes both to the provincial legislation in Quebec as well as Bill C-14. Finally, those requesting MAiD must be able to make a voluntary request and give informed consent at the time of administration. In addition to eligibility criteria, there are some important safeguards outlined, such as eligibility for MAiD must be determined by two practitioners, either physicians or nurse practitioners who are independent of one another, and the second one must also be independent of the patient. Once the patient has been determined to be eligible, he or she must then submit a written request for MAiD in the presence of two independent witnesses. There must be a 10-day waiting period, although this can be waived under certain clinical circumstances, and one of the most common would be a patient who is deteriorating rapidly and could not be expected to give informed consent at the end of that 10-day period. And finally, the patient must be able to provide consent immediately prior to the procedure. This requirement has proven somewhat challenging for pain and symptom management. Both providers and patients have had to consider the medications they use so that patients can remain competent to provide that final consent. Now, these statistics are somewhat dated, as the last report we have is now almost a year old. There are now new and more detailed reporting requirements that went into effect in November of last year, but this is the best we have. The total number of reported MAiD deaths between December 10th, 2015 and October 31st, 2018 was 6,749. Of those deaths, only 6 were self-administered, and anywhere from 4 to 7% were administered by nurse practitioners. The average age was 72 to 73, and there was a relatively equal distribution between men and women. The vast majority of MAiD deaths are occurring in Ontario and BC, and either in the hospital or the home. So let me now introduce you to our study. The purpose of this study was to explore the policy, practice, and ethical implications of MAiD for nursing. In doing this study, we had a pretty strong hunch that the nursing role in assisted death was much more important than what was reflected in the international literature. There was some literature around nurses' experiences, primarily from Europe, but we were struck by how little there was. And knowing that nurses are the ones who work closest to patients around the time of death, we suspected that they played important roles in care that were not always visible. This was a 3-phase study in which we first conducted a systematic review, then a primary qualitative study, and then a synthesis of the two. So we've published a number of articles from the systematic review that are available open access, and the remaining results will be published within the next year or so. I want to acknowledge our team. We're so grateful to have such a knowledgeable group. And we also want to acknowledge the funding provided through the Canadian Institutes of Health Research and our valuable partnership with the Canadian Nurses Association, and to specifically mention Josette Roussel. As part of our policy review, we gathered nursing regulatory documents from all provinces and territories across Canada. It was interesting to see how much variability there was in the direction provided to registered nurses and nurse practitioners. The guidance varied from a single succinct page to multiple page documents in which nurses were provided with all kinds of ancillary information to support their practice. Further, it was interesting to see how some regulatory bodies assumed that nurses would participate unless they opted out through conscientious objection, while other documents assumed an opt-in approach. In other words, the language implied that nurses didn't participate unless they chose to do so. And this mostly likely reflects the socio-cultural context of each province and their response to actually what remains a somewhat morally contentious procedure. We were also interested in what the perceived registered nursing responsibilities were. In some instances, this included participating in the assessment of patient competency. This responsibility recognized that nurses are sometimes the ones who know the patients best. Nurses were also responsible for providing information to patients and families, although this could be as simple as referring patients to the correct provider in response to a direct request for MAiD. Nursing responsibilities also included coordinating the MAiD process, preparing equipment and intravenous access for medication delivery, coordinating and informing healthcare personnel related to the MAiD procedure, documenting nursing care provided, supporting patients and significant others, and of course providing post-death care. As these were regulatory documents and the primary role of a regulatory body is protection of the public, there were a number of safety concerns highlighted. Registered nurses needed to be sure that they were not counseling patients to receive MAiD, that they played no role in administering the medications unless they were nurse practitioners, that they did not witness consents if they were providing direct care, and that they only documented the care they provided. Finally, there was some indication that although nurses did not implement the safeguards, they needed to be sure they were being followed if they chose to take part. In other words, nurses needed to be responsible for their own practice in relation to the legislation. We also examined the ethical literature as we were interested in the arguments that had been made both for and against nurses' participation in assisted death. This was important because nursing associations have been divided on the ethical acceptability of nurse participation. For example, the American Nurses Association, until recently, has taken a strong stand against nursing participation, whereas the Canadian Nurses Association has advocated on behalf of nursing participation. We located 43 articles that discuss the ethical implications of nurses' participation. We were particularly interested in how nursing authors constructed their arguments. Many based their arguments upon traditional biomedical ethics, whereas others argued on the basis on the nature of nursing. In other words, is there something special about nursing that means we should or should not participate in this? Some articles analyze the difference between MAiD and other similar acts, example, withdrawal of treatment, and only a few looked at assisted death from a social justice perspective. What was most surprising to us was how little literature had been written from a Canadian perspective, and we're still a little bit puzzled by that. In this aspect of the literature review, we were interested in knowing more about nurses' experiences. As such, we looked for qualitative articles and found 6 that represented the experiences of 55 nurses from Canada, Belgium, and the Netherlands. Across these articles, we discovered that nurses performed a central role in discerning and negotiating initial patient inquiries about assisted death. Indeed, it is often nurses who receive those first inquiries and must do the hard work of discerning the intent of the request, particularly when it is often communicated in somewhat veiled language. We further learned that even in contexts where nurses are not assessors and providers, nurses provide the wraparound care for patients, families, and other healthcare providers. They are the ones that work with patients from beginning to end. Finally, and not surprisingly, participating in assisted death was impactful for nurses and required significant personal and professional moral work. And we will talk more about this in the context of our study. But before we go too much further, we would like to actually take a little poll around your experience with assisted death. And so we'd like to ask you 2 questions. First of all, do you feel confident in your knowledge of MAiD? Yes, no, or unsure. The second question we want to ask you about, and we'll ask you that in a couple of minutes here. And let's move on while you answer that question. So we have the poll results in front of us. Do you feel confident in your knowledge of MAiD? 32% responded yes, 48% responded no, and 20% responded unsure. So I want to now talk about Canadian nurses' experiences. So those were the results of our literature review. We'll now talk about the qualitative findings of Canadian nurses' experiences with MAiD. And it's important to note that to be eligible for the study, nurses were not required to have participated in a MAiD death. We were interested in hearing nurses' experiences from across the spectrum of participation and non-participation. Having said that, the vast majority of nurses in our study had some direct experience, and even those who self-identified as conscientious objectors had some experience with negotiating that conscientious objection in the context of MAiD-related care. And so you have the demographic interview results in front of you. We conducted 60 interviews with 59 nurses. You will note from these demographics that the majority resided in BC and Ontario, which is not surprising in light of the fact that this is where the majority of MAiD deaths occur. This was an experienced group of nurses. 38% had been in practice for greater than 25 years. Most worked in home and community care. We had a nice representation from both RNs and NPs in light of the numbers in Canada. And you will note that we have very little diversity in our sample, both in terms of ethnicity and gender. 9 of our participants were declared conscientious objectors, and a further 75% described themselves as being religious or spiritual. I'm going now to describe the findings in relation to our 3 objectives today. First, we're going to talk about nursing work, then about nursing art, and finally about nurses' moral experiences. But before we do that today, we'd like to ask you the second question in our poll. And the question is, how many of you have been involved in the MAiD process in any way? And if you're answering yes, that could be in relation to having received a request or been actually involved in the process. No means no, I've had no experience to date at all. So I first want to talk about nursing work. How are contextual factors influencing nurses' work and experiences? At the time we collected data for this study, there was wide variability in the amount and quality of practice supports developed for nurses. In some geographic areas, there were fully developed teams and resources. In others, they'd not yet managed to craft policies even at the regional level. Many nurses told stories of having to do their first MAiD case in a virtual void of knowledge and policies. These experiences were difficult. One of the factors that influenced the development of policies was nursing leadership. Those leaders who took a proactive approach made a key difference in nurses' experiences. It was very difficult for nurses who had leaders who chose to ignore the MAiD developments and hence left them without support when the inevitable MAiD case came. But what was most important on the part of nursing leadership was that they were effective in supporting a range of moral responses. Leaders who were able to set aside their own support or lack of support for MAiD and create effective climates where nurses could easily participate or choose not to participate were most effective. This was most evident in how the leaders facilitated conversations across differing perspectives. Nurses who were MAiD advocates and those who were conscientious objectors described experiencing the same stigma and shunning, sometimes from those in leadership. Physicians played a similarly influential role, primarily as gatekeepers to the MAiD system. Those who were opposed to MAiD had various ways of discouraging patients from seeking MAiD, and many patients did not know that they could refer themselves for assessment without going to a physician. There were also concerns about palliative physicians dropping care once a client had chosen MAiD. A system issue that caused a great deal of concern throughout our data was poor access that many Canadians have to palliative care. Without such access, patients are left alone without a true choice about which option to pursue. Indeed, there are a number of stories in our data that suggest that patients used MAiD as a form of resistance to an inadequate system. And this final point is embedded in this quote from a palliative care provider. Now, I'm not going to read all the quotes as we go through these slides, but what I've tried to do is put quotes in each of these slides that illustrate the points that I'm trying to make. Participants talked about the importance of teamwork, even if that team only consisted of 2 providers who knew and trusted one another. Some of our most difficult stories came from providers who had to work in isolation, not of their own choosing, but because there were simply no other individuals in their area willing to take part. Nurses who were comfortable with MAiD often took on the role of being the go-to person for provisions so that continuity of care was possible when MAiD was provided by outsiders. They also realized that relationships were fundamental to well-being under such difficult work. Some nurses saw their role as supporting everyone, patients, families, and healthcare providers alike. Finally, because of privacy issues, some healthcare providers felt shut out. This was particularly the case in residential care and in community where healthcare aides might not know that a long-term client would be dying that day, or where community health nurses were never notified that their long-term care client had chosen MAiD. This is a quote, this final one, from long-term care. For those of you who have worked in palliative care, you know how important it is to support a good death. You go to extensive lengths to accomplish this, and yet for most, we miss the time of death. Now imagine that you know for sure when and how that death is going to happen. That same aim toward a good death is magnified in this situation. Nurses determined to ensure that this final act is exactly what patients want. Priority tasks such as organizing referrals, finding assessors and providers, filling out extensive paperwork, and finding physical space must all be completed in a timely, patient-centered manner. This is particularly challenging in the MAiD deaths that need to be expedited because it's anticipated that patients will lose competence during that 10-day waiting period. It's important to note that each of these tasks could be challenging. There might be no providers or physical space. Also, patients and families also request this procedure in off hours, and yet some nurses must do it for free if it's not done as part of their regular working hours. And the quote from this participant really, I think, reflects that complexity. The legislation that governs MAiD appears to be precise, but actually leaves a great deal of room for clinician judgment, and this judgment has been recognized by the courts. One of the safeguards in the legislation is that the provider should also have done one of the assessments, but keep in mind that patients often have their assessments not because they want MAiD imminently, but because they want it as a safety plan. In that case, it could stretch on for months, and the original assessors may no longer be available. The quote from this nurse typifies the complexity of MAiD in such a scenario. Further, how does one determine foreseeable death? Here is where clinician judgment becomes paramount. Many nurses have developed assessment and screening tools such as frailty scales to facilitate their judgment, but effective mentorship was critical to forming these judgments. The Canadian Association of MAiD Assessors and Providers has a listserv to support such mentorship, but during the time of this study, it was open primarily to those who actually did provisions. So making these clinical judgments contrasted profoundly with the preciseness of the new reporting requirements. Nurses found it difficult to tick off boxes that imply that these decisions are black and white. As one participant phrased it, it feels like the difference between MAiD and murder. Here, another participant describes the legal fears that attends such a clinical judgment, and that's evident in this final quote that I have put here. The right for healthcare providers to conscientiously object to participation in MAiD is enshrined in the legislation. However, in this study, there were many challenges to realizing this right. In some situations, very real accommodations were made for nurses who chose not to take part, such as a day off work without pay. In other situations, nurses were required to stay with patient care, except for the moment of medication administration. Across studies, however, we have found that conscientious objection is not black and white. For many nurses, it's a journey of discovery. They don't know how they're going to feel until they actually experience a MAiD death. There was also an interesting dynamic on teams that contained both MAiD proponents and conscientious objectors. The MAiD proponents might not bring up the topic for fear of offending their colleagues, yet their conscientiously objecting colleagues might interpret this as exclusion. The most problematic situations was when the MAiD role was embedded within employment. Nurses described being interviewed for a position and being asked if they would participate in MAiD. Others who had casual status worried that they would no longer have employment if they conscientiously objected. These are actually human rights issues, and these are not easy decisions for those who identify as conscientious objectors. And as this final quote suggests, the greatest fear of those who were conscientious objectors were that they were abandoning their patients, a critical source of moral tension. They were distressed by being involved, and they were distressed by not being involved. So I want to move into nursing art now. So what do we say when we mean nursing art? Nursing art is the ways in which nurses learn to humanize the healthcare experience. And so we want to illustrate some of the ways that nurses did this in this study. From the perspective of our participants, those initial conversations about MAiD were critical. Indeed, they were referred to as legacy conversations. NPs who acted as assessors had developed highly skilled conversational routines that took a very direct and blunt approach. Initially, some nurses were intimidated by having to go into homes to do such a personal assessment. However, they soon learned that patients trusted them with this immediate and deep intimacy. However, there were complicating factors of mental health issues, homelessness, or diminished social skills. Registered nurses who were less certain of their role and boundaries in these initial conversations. Nurses often established these boundaries according to their own beliefs about MAiD. If they were MAiD proponents, some had even decided to introduce it as an option for patients who did not necessarily inquire about it. This decision was usually made after nurses had discovered how ill-informed some patients were. But for those nurses working in institutional settings, time to have these conversations was always an issue. The challenges of determining the correct referral path was often difficult because nurses had to decide whether they were going to refer to palliative or to social work or to the MAiD team. And so what they found was this conversation in itself was an incredibly important intervention. It was to ensuring that patients had made the best choice that was for them. So I want to talk for a minute about artful principles. Beyond these initial conversations, here are some of the principles that nurses shared with us about good nursing care in the context of MAiD. We call them principles because they express a particular idea which was then adapted to each patient's situation. First of all, make yourself small and invisible. And I'm only going to read really one quote from each of these slides. We kind of figured out how to work together in trying to make ourselves as small as possible in the room, because this is never about the provider. It's always about the family. And so I've been on my hands and knees at the bedside exchanging syringes of medication. Second principle, make the acting conspicuous. Another participant said, I think it's really nice to be able to go to a completely separate room to draw up the medication. To do that in front of the family, it just felt so crass. I remember shifting my body around trying to hide what we were doing because to me it just seemed that for them to see that didn't seem right. Third, take your emotional cue from the patient and family. One participant said it was quite funny. I mean, it was a very emotional time because we were so close with the family physically as they were saying their final goodbyes, and we were having a bit of a hard time keeping it together. But literally, we had to move ourselves onto this king bed just to reach the IV line, and his daughters were teasing him about being in bed with his providers. Fourth, keep it patient-centered, and I'm only going to read the last quote here. Is there any other experiences I can facilitate for you because you know on this date, at this time, you'll be taking your last breath. And you can see from the first quote, nurses had all kinds of questions that they would ask patients to ensure that these final moments were patient-centered. Anticipate problems. Think back to how important it is for nurses to get this final moment right. Then imagine all the things that could go wrong in that moment, because that's exactly what nurses did. They would lay awake at night wondering if they could get IV access easily and rapidly. Some said that the stress of this alone was enough to deter them from doing any more provisions. Others did in-home assessments so that they could be really prepared and maybe even started the IV the night before. Next principle, teach everyone what to expect. This participant said, I go into quite a bit of detail about the day of the provision and what to expect, and things to think about. Which medications are administered, how long they take, how the coroner's involvement, because that's an unusual experience for most people. They don't have to do that 99% of the time. Next principle, watch and intervene. This participant said, if the patient's head starts to droop or the patient looks uncomfortable, don't feel afraid to move the patient to make them look more comfortable. Patients and families have said to me, thank you for moving his head. He looked like he was drowning, or he's flopped over and has hit the bed. So how did nurses go about developing this nursing competence and learning these artful ways? Many spoke of taking the required health region courses, and those certainly helped. But these courses didn't prepare them for the realities of practice. Instead, they spoke of going with other, more seasoned individuals and learning the ropes. Having that supportive presence was particularly important for the first death. And again, some of our most difficult stories came from those who'd had to do these first deaths alone with no support. Nurses further described the importance of debriefing and a particular type of debriefing. It needed to happen with those who knew what this experience was like, and it was best focused on improving the quality of care. But taking a patient-focused approach, it allowed those involved to share their experiences or not as they saw fit. Finally, I'm going to talk briefly about nurses' moral journeys, what moral tensions characterize nurses' response to MAiD. And I call it a journey because it's something that developed as nurses walked the path. First of all, I think it's important to recognize that this was really a different death. Nurses are now in the position of knowing the day and the moment, so there's an opportunity to create a memorable experience for patients and families, and nurses went to great lengths to do that. However, these experiences are often memorable in not so desirable ways, and nurses talked about that stark transition for life to death and how that's new and how graying was particularly impactful. And the other thing that was layered onto that is that the fact that many of these patients still appear relatively well. So it's an early death without obvious suffering, and that's really illustrated in some of the quotes we have here. And so it's impactful across a spectrum. And these first quotes that I've put here are really how it can be a very positive experience. As this first participant said, I found the whole experience to be incredibly profound and very fit for nurses to do. But then on this next slide, I've illustrated how it can also be not such a positive experience. And so you will have access to these slides, and so you can read some of these more difficult experiences, but I'm going to read just the second one. It was an emotional experience, not a sad emotional experience, because, she made the choice and it was her choice. But I found myself crying afterwards in my car, and it was just this overload of emotion. I just needed to let that go. So what were some of the influencing factors for this overwhelming emotion? Certainly proximity to the act. Nurses talked about the fact that in theory, they could actually be very positive about MAiD, but actually they were not always sure that they could actually deliver the medication themselves. And that seemed to be one of the most influencing factors. The second is the role of significant others. Our participants suggested that it's very important to have a supportive around environment around you, because this requires a lot of emotional work. And the third, feelings of stigma and guilt were fairly present in some of our participants. So what were some of the moral responses? How did nurses make sense of this? I like to use the analogy of riding the moral elephant from the work of Jonathan Haidt. He suggests that our moral responses are like riding an elephant. The elephant is our embedded moral tuitions that have deep roots in our history and culture. But then nurses have this way that they ride the elephant by using their reasoning to make sense of what's happening. And so that's what I'm going to talk about. Some of our moral intuitions. First, I would say that many participants spoke of that deeply embedded rule, thou shalt not kill. Others spoke of the intense feeling that they have that they're playing God. And I think why this middle quote is so interesting is the participant clearly identified a disjuncture between her rationality and her feelings. And finally, others spoke of the mystery of death and pondered whether MAiD was interrupting some natural life transition. Then there were moral experiences. These experiences shaped this deep moral intuition. Specifically, when death was peaceful and patients and families were grateful, it really helped nurses' moral tensions. However, if death did not go well, if patients showed fear, or if family members disagreed with what was going on, then it was much more difficult. In some of the worst cases, families would show outright hostility or question nurses who were involved, and this created lasting memories. Despite these intuitions and experiences, nurses tried to ride the elephant as much as possible by rehearsing reasons for their participation. One of the most common was the alleviation of suffering. Many of our participants had worked in areas where they had participated, had seen just too much human suffering. The other thing that nurses often referred to is the ability of patients to have autonomy and control. Nurses have a profound legacy of patient-centered and nurse-decentered care. They've learned over the years to care for patients well, regardless of how they feel about their lifestyles and behavior. And that translated into the care of MAiD. Nurses remembered this was not just about them. Nurses also talked about comparing their practice in MAiD with other similar practices, whether that be with the removal of life support or the self-administration of MAiD. The previous slide explained the role of rationality in support of MAiD. These, on the present side, were the most common reasons for not participating. The first was the unknown phenomenology of death and suffering that in turn made knowing the rightness or wrongness of MAiD somewhat unknowable. This participant actually held her beliefs loosely, recognizing that they could change under extreme suffering. Others spoke of not just thinking about autonomy in relation to MAiD, but about the big picture of the social good. A real challenge for many was the idea of healthcare-induced suffering. They realized that many of our systems are inefficient and highly depersonalizing. They suggested that MAiD was a poor way to solve this iatrogenic suffering. Finally, some suggested that nursing was not about fixing people, but about being with them in the midst of their suffering. So in conclusion, nurses, both RNs and NPs, have important roles and responsibilities in ensuring high quality care in the process of considering and implementing MAiD. Practice supports need to reflect the precision and obligations of a legislated approach to assisted death. MAiD has a significant impact on nurses across levels of involvement or non-involvement. And artful nursing practice in the context of MAiD is developing and needs to be shared. Competence and confidence is developed organically. And so our recommendations from this study follow really from those conclusions. Ensure that nursing practice supports are developed and made readily available, even and perhaps especially in those contexts where the perception is that they are not required. Provide supported venues for conversations about the ongoing emotional and moral work. recognize the importance of the early conversations about MAiD and prepare nurses with best practices, set an organizational climate that allows for a full range of healthcare provider, client, and family moral responses to MAiD, and finally, establish better mechanisms to facilitate nurses' decisions to not take part in MAiD. Thank you, and Josette, I will turn it back to you.
Thank you, Barb. We've gone through a lot of information from this study, and I know the participants will have some questions in a few minutes. But I want to start the conversation with some of the questions that we have received, and I want to start with one question, Barb. How can we best support those who have chosen to take part of MAiD and those who have not?
I think that's such an important question, and I think it really comes back to supporting healthcare climates where leaders have really thought about how to be supportive of both of those positions and to make it easy for people to take both of those positions. And then beyond that, I think we can't underestimate the importance of supportive conversations. So nurses told us over and over again how important it was to talk about this and to not sort of hide this under the rug somewhere and only have it come into conversations when it's difficult, and to recognize that people will have different perspectives around this, but in our experience in this study from a nursing perspective, the common ground is compassion. Nurses across our studies had this inherent desire to form a compassionate response wherever they landed on the spectrum of participation. And so that's, I think, where we can really begin from.
Thank you, Barb. I'm just going to see how a participant have answered the polling questions. We have a few polling questions, and I see that the majority have responded. We're going to leave it up just a few more seconds while I go to the Q&A box. There is a question, Barb, and that's something that we've heard through the study, is that, did I hear that you mentioned that a nurse offered or suggested MAiD to a patient? I did not think that this was permissible. I was told that a patient had to suggest it themselves. Barb, can you make comments on this? Because we've learned through the study that this was a question that was raised by the participants.
Yeah, so this is really actually one of the most interesting developments, I think, in practice across Canada. And it's not just registered nurses that are struggling with this, but physicians and nurse practitioners. And it really comes back to the dilemma of, you know, should we only be providing information about MAiD if somebody makes an explicit request? Or should information about MAiD be provided as part of a series of end-of-life options? And I can imagine, you can imagine that depending upon how people feel about MAiD really determines how practitioners tend to answer, you know, those two questions. The regulatory bodies, really the most important thing is that you don't counsel patients to seek MAiD, but some nurses and nurse practitioners across the country are providing information about MAiD if in their assessment that is what the patient is requesting. And so, of course, that's a very sophisticated conversation. They have to first determine that this really is, that the patient really is talking about MAiD and not that question that so often comes up in palliative care of, can you help me to die? Those are actually really can be two very different requests. So it requires a fair bit of conversational sophistication. But yes, there are some nurses across the country who are taking the initiative to provide information to patients about MAiD if in their best clinical judgment, that's the question the patient is asking.
Thank you, Barb. There's a few more questions that I will go through. It's it's about how, Barb, do you see, based on what you've known, what you've learned with the study, how is the information being transmitted to nursing students within educational program to prepare them for future practices? Have you heard anything towards that question?
So to my knowledge, there's no evidence that's been published to date around how this is being integrated into undergraduate nursing programs. And so my best knowledge is anecdotal at this point. And I think it's important to recognize that in many provinces, this is not an entry to practice requirement. You are required to do additional education prior to participating in MAiD. But nevertheless, I think this is a great question, and I think we have a real responsibility to prepare nursing students. And so what I have seen in most undergraduate nursing curriculum is an introduction to MAiD, and certainly, you know, some of the preliminary information that I presented today around what it is, what are the safeguards, what are the eligibility requirements. But I think the thing that we really, really need to be doing for nursing students is helping them to do that hard moral work of deciding whether they want to participate in MAiD when they get into the clinical practice context after appropriate education. And I think, you know, it's interesting. It's that whole thing of trying to sort out the personal and the professional, and how do my personal values and beliefs intersect with professional treatments, professional obligations. And so I would say, as I think about what needs to happen in nursing undergraduate education, that is really the most critical piece.
Thank you, Barb. I'm going to go now to a question from someone who is in the process of setting up a unit with some end-of-life care beds, and they're anticipating that may come up in the conversation. And the question is about the licensed practical nurse role, and if you can provide any advice based on the information that you've learned from the study participant.
So when we did a review of the regulatory documents, some of those documents from across Canada automatically include the licensed practical nurse role. And so if you're from one of those provinces, and that publication is free access on the internet, you'll get the reference for that, and so you'll see which documents include across Canada the LPN role within those criteria. If you happen to be in a province where it's not covered under those regulatory documents, I think the most critical piece is getting access to your regulatory documents, and then asking the question of your health region, how they envision the LPN role. We didn't actually set out to review all the LPN documents from across Canada, but the same principles would apply in that, you know, you first start with your regulatory body in terms of what's acceptable practice, but then you also need to check the regulations within your particular region. But of course, I think it goes without saying that as you go to enter into this landscape, the best thing you can do is, again, have those series of conversations, have those educational sessions, so that people aren't left with that first MAiD case without good education, good understanding from one another, where everybody is on this spectrum and doing that preliminary work.
Thank you, Barb. We've received a question around what steps should a nurse take when they receive information that is inconsistent with the doctor's determination that the person is eligible for MAiD. So that's when there's contradictions, or it's not the same, as there's an inconsistency with the physician's determination and what the nurse perceives, takes on and sees.
Yes, this is such a tricky question, and it really did come up in our data as well, because this is happening to nurses and does happen. And I think there is in that case an obligation to bring that concern. Certainly within the regulatory documents, there is an obligation to bring that concern to your most direct line leadership, as we always do when a practice issue comes to bear. And then I think if if that doesn't bring resolution, then of course remember we have the Canadian Nurses Protective Society. So there's all kinds of practice advisors at various levels that you can seek help with. And if you run into this, I would say that would be your most important thing to do right there. First of all, bring your concern to your frontline leadership, and then work through the other areas as well.
Thank you. Was there any information or support that you found that was provided to family members during the process? Did you hear from that in your interviews with nurses?
Nurses are just so brilliant at family-centered care, and throughout our interviews there was just a vast amount of data about how registered nurses and nurse practitioners went about preparing patients and families. And so when they would educate families, they would educate them multiple times. They would make themselves available to families. They would stand firm for families through the process, helping them. And of course, they would walk through with them into the bereavement process. And of course, having said that, when families were at different situations around their agreement, around the MAiD process, those were also the most challenging clinical scenarios for nurses. And so it was a very, very, I think, difficult issue, and I think we need certainly more evidence around how nurses can do this family-centered care. But yes, there's some really good examples of how nurses do this brilliantly.
Thank you, Barb. There's a question around if a nurse can refuse to assist in MAiD. Did that come up in your discussion with nurses?
Absolutely. So you're right, is to be a conscientious objector. That's enshrined within the law. You have some responsibilities that go with that right. And the first is to inform your employer that you are indeed in that position. And then the second is to not abandon your patients. And so to always ensure that there is some continuity of care. So the other piece that goes with that is you will notice that across the country, health employers have put in place different policies as to how to support conscientious objectors. And so you need to also ask about that. What is your right within that? And as I mentioned, I alluded to in the presentation, there's a whole continuum. So your right actually may be only that you're able to step out of the room at the moment of medication administration, but you may be asked to continue with that patient and family other than for that moment. Other workplaces are allowing nurses to actually step back significantly, meaning changing patient assignments and doing different things. So this is something that you definitely need to work closely with your employer on, but you absolutely have the right to be a conscientious objector.
Thank you, Barb. There's a question related to one reporting system in Alberta called the Netcare reporting system. Barb, you may know about this reporting system, and apparently they do not provide discharge summaries for clients who have died as a result of MAiD. So they are asking to comment whether MAiD death will be captured in Netcare or where the documentation is to take place. Have you heard of this situation? It may be specific to that jurisdiction only.
Yes, I'm not familiar with that particular situation, but I do know that the issue of how to report a MAiD death has been problematic across the country because there are a number of factors that come into play that are really bigger than MAiD in terms of how to capture them and benefits that people might have as a result of that. So that piece is a little beyond our research, but I do believe that that's something that does need to be worked out, and Alberta would not be specific to Alberta. It has been a challenge across the country in terms of how to report and making sure that there's communication across systems, across providers, and of course layered onto that is the issue of privacy. And how do we meet that very delicate balance between ensuring the privacy of patients and families while including those people that need to know to ensure good continuity of care. So it has been a problematic issue.
Thank you, Barb. I'm going to go over now a different type of question, and it's about providing the service. How can this service be provided in remote and isolated communities across Canada? Have you heard of these issues during the interviews?
Yeah, so I think it's first of all, yes, really important when these are remote and isolated communities. I think it's really important to involve the communities in this conversation, and I think in particular of Indigenous communities, and really making sure that their sovereignty over those communities is respected. And so that's one separate issue. We don't know a lot about that within the MAiD research yet, and I think that's a very important part of research that still needs to be done. But if we're then looking at the issue in terms of, you know, remoteness and how do we do that, there are a number of systems that are being used across Canada. One is a team. Or an individual who is actually paid to travel to these remote places. You can do assessments via web-based assessments in some cases, and so there are some systems in place to assist with that. In other cases, there are perhaps single providers that will travel out of their jurisdiction to close jurisdictions to do that. So I don't think we've solved that entirely yet. But given that many of our remote communities are Indigenous, I do think we need to partner with them very carefully on that issue.
Thank you, Barb. I'm gonna just go to one last question. It's related to if there is any, if you've heard of any support programs or follow-up post-medical assistance in dying for families. Have you heard of that through the interviews?
Yes, there is. Actually, I heard about it at the Canadian Association of MAiD Assessors and Providers, the CAMAP conference. There is now a family support network, and I'm sure they're cropping up all over the country, but this was the one that was presented to us at the last conference. And so there is research indicating that this population has very unique needs in relation to bereavement, and we're learning some very interesting things, mostly back east, from evidence back east, about how to do follow-up with patients and families and who should do that follow-up. So yes, there are some networks out there now, and we can certainly add those to the reference list.
Thank you, Barb. That's all the time we had for today's discussion. We've had great questions through the Q&A box, and for those of you who have not had your question answered, we will follow up by email. I want to thank Barb for her excellent presentation. It's been great to be part of this research group, and there will be a few publications, as Barb said, publications that will provide more information on the research findings. And the webinar is being recorded and will be accessible. We do hope that this webinar has been useful and helpful to know a bit more about medical assistance in dying. It's still early. It has been only a few years, and we've learned a lot through this research. You will be able to access the recording from the YouTube's channel. And our next webinar will be in October, and it's about the 2019 Community Health Nursing Standards of Practice. And more details will be provided then. It's going to be over lunchtime, and I hope many of you will participate in this webinar. Thanks again to the participants, to our speaker today, Barb, and have a good day.
Thank you, Josette.
Thank you.